So I just want to say a few words at the beginning, just to say thank you to Professor Gentili. Welcome on behalf of the Algerian Society of Neurosurgery in collaboration with the Federation, Maghrebian Federation of Neurosurgery and CANS. And it's a great honor to have you as a guest speaker. I just give the floor to Professor Bouyousef, who, as you know, is our pioneer in Maghrebian countries in endoscopy and in Africa also. So I will let him talk to introduce you. Professor Bouyousef, could you introduce Professor Gentili? Do you hear me? Professor Bouyousef?
Professeur Bouyousef?
Professor Bouyousef?
Justement.
Regarde. He cannot hear you.
Non. Logiquement, si.
Non, non, il est muet.
Non, non, il n'est pas muet.
Si, chez moi, je le vois muet. Attends. Tu peux lui débloquer? Professeur Bouyousef.
He cannot hear you, Saad.
Hein?
I don't think he can hear you.
Monsieur Bouyousef.
I think he's gone off for some reason.
Yes, I think he will try to...
Again, yeah.
Yes, to reconnect. So just to say one word about our panelists, we have with us Professor Abdesamad El-Wahabi from Rabat. He's, as everybody knows, head of department in Hôpital de Spécialité in Rabat. He is also currently the co-chair of the Global Neurosurgery Committee of WFNS, and he was also past vice president for Africa in WFNS. We have also Professor Mehdi Dermoul from Tunisia. He is currently the head of department of neurosurgery in Monastir, which is a very beautiful town.
Thank you.
In Tunisia, wonderful town. And so I said to them, welcome. We are also supposed to have our colleague from Mauritania, Professor Ould Sidi Mohamed. Maybe he has some problems of connection. Is Professor Bouyousef here? I think it's complicated. Cyril, tu peux l'appeler? Sinon, on va commencer.
Yes. I have some problem with the sound, but now it's good.
Yes, we guess that.
Hi.
Okay. So
welcome.
You have the floor.
Sorry.
We can hear you now.
Pourquoi vous êtes venu?
On vous entend, hein?
J'espérais pouvoir parler à votre mari. Il n'est pas là. Eh bien, vous pourrez peut-être m'aider.
Yes.
C'est bon? On vous entend.
D'accord. Je peux prendre la parole?
Cyril, le micro à Bouyousef. C'est pas possible.
C'est bon?
Oui, oui, c'est bon, c'est bon.
Hi, good evening, everybody. It's a real pleasure for me to be panelists this evening with our guest, Professor Fred Gentili, and share with you this fourth webinar of the Algerian Society of Neurosurgery. This webinar, as said by Suad before, is organized by the Algerian Society and also by the Maghreban and the African Society of Neurosurgery. Thanks for Professor Bakhti, our president, for all this effort you do with Nabila Houari. And I have a good pleasure also to have with me in the panel, my friend, Professor Abdessamad Al-Wahabi, and Sidi Mohammed, I don't know if he's here, and also Professor Darmoul and Professor Kamal Bouaita from Algeria. Darmoul from Tunisia is with us today. Our special guest today is well known from all over the world. Is Professor Fred Gentili, professor of Department of Surgery, Division of Neurosurgery, University of Toronto. He entered the neurosurgical training at the same university. He completed his training becoming a fellow in the Royal College of Physicians and Surgeons of Canada in 1980, and also completed his clinical fellowship at the University of Zurich with Professor Yazar Gil, and also in London, in England, with Professor Simon. Dr. Gentili joined the neurosurgery faculty of Toronto University in 1982. He's currently full professor. He's founding the North American School-Based Society and member of School-Based Committee of WFNS, and also member of Neuroendoscopy Committee of WFNS. He currently is the former chair of 2 academics, hospital and university chairs, the Queen Houston Chair in Skull-Based Surgery, is the first and the only academic chair in skull-based in Canada. He is delegate of the WFNS, representing the Canada in this association. Professor Gentili is member of numerous neurosurgical societies and is on the editorial board of several international journals. He has authored more than 100 publications and over 25 books chapters. He has received numerous honors and awards during his career, including the gold medal from the University of Messina and the College of Physicians and Surgeons of Ontario. He is honorary member of both Italian and Spanish neurological societies. His main interests are skull-based surgery using both open and minimal invasive endoscopic surgery, and also pituitary surgery and gamma knife neurosurgery. He is today our special guest to talk about anterior skull-based meningiomas. Is there any role for the endoscopic approach? I can say myself, yes, here is a role. Thank you for your attention. You have Suad, if anyone from the panel had to say something. Do you hear me?
Just now, we will let Professor Gentili make his presentation. Do you hear me? No, we will let Professor Gentili to make the presentation.
Can everybody hear me?
Yes.
Okay, good. First of all, Professor Bouyoussef, thank you very much for that very, very kind introduction. I want to thank, first of all, Saud very much for the kind introduction, at least invitation. I'm very honored to give this webinar. And I want to welcome all the other panelists that are here. You see where I come from. I come from Toronto in Canada. It's the largest city in Canada, about 6 million population, next to the beautiful Lake Ontario, one of the 5 Great Lakes of North America. And it's a beautiful city. And all I could say is please come and visit. Anytime you are invited to come and visit us. So my talk today is on the role of anterior skull-base meningioma, the role of endoscopic techniques, trying to look at some indications, some limitation, and some results, because we have to show some results. I always say, you know, we can show beautiful videos for the whole lecture, but that's not enough. In the end, you want to know what are the results of these. So it's very important to give, you know, results. Now, there's no question, I think everyone listening would agree with me that endoscopic approaches has had a significant impact in skull-base surgery over the last decade and a half. I think anybody who would say that does not have any, you know, it's not right. It's had a significant impact. This is our series now of over 500 cases of expanded endoscopic procedures. And you can see here the different pathologies. Pituitary, I have it here, but these are giant pituitaries that required an expanded approach. And there's no question now that this type of tumors that we operated before, we craniotomy, lateral rhinotomy, whether they're encephalocele, you can see here, osteomas, angiofibromas, cholesterol granulomas of the petrous apex, schwannomas, all of these now can be done using a pure endoscopic approach. I have not, you can see them here, I've not repaired a CSF leak now open for a decade, 10 years or more. This can all be done using a pure endoscopic approach. You can see this anterior encephalocele, middle fossa encephalocele, cholesterol granuloma of the petrous apex, beautiful, before requiring open middle fossa approaches, extensive, all can be done using an endoscopic approach. Look at this giant juvenile angiofibroma, capillary hemangioma, hemangiopericytoma, again, all done using a pure endoscopic approach. So in my mind, you know, these procedures, for these procedures, the endoscopic approach has replaced the open procedures in the great majority of cases. But there remains controversy in skull-base surgery. There's no question. All of you who do this do it. The whole issue of cavernous sinus surgery. Should we be going to the cavernous sinus? I've always been one to say, no, I don't like, ever was a proponent of cavernous sinus surgery, but some people still do. The whole role of radiosurgery. As you saw from my thing, I'm a gamma knife surgeon too. I'm an endoscopic, I'm an open, but I also do gamma knife. But there's some people suggest that, you know, you should never do radiosurgery for skull-base, you know, and there's controversy. And then the whole role of endoscopic techniques, which I'm going to discuss today. But my view, my philosophy is controversy in surgery is very good. We need controversy. It stimulates discussion, can drive progress. What I do not think is very useful is what I call dogma. Somebody who tells you you must never do this way, you must always do this way, to me, that is not a good situation. And as Steve Jobs, as you know, of the iPhone says, don't be trapped by dogma, which is living in other people's thinking, not your own. So we come to anterior skull-base meningioma. Is there any role? And there are some people who would say never. This is a stupid idea. You must, you know, never do it. Others say always and sometimes. So I want to go a little bit about why all this controversy. Why are we still having all this controversy? Well, it's very simple. First of all, let me just say, I was going to say, this controversy is not new. If you look at this slide of here of Harvey Cushing, He did one of the first tuberculum meningioma back in 1916. That's 104 years or whatever it is. But look at what he said in the end. What is the best method of exposure? And he said, the pioneers blazed trails into a new country, and their followers instinctively take the shortest and safest route. So what is the shortest and safest route for anterior skull-base meningiomas? Well, why all the controversy? This is why. Because we have many good open approaches for anterior skull-base meningiomas. We have the bilateral approaches, the bilateral subfrontal, subcranial, bilateral transbasal interhemispheric, which is my favorite approach for the open approaches. We have many unilateral approaches, as we all know, the subfrontal with osteotomy. We have the pterional, the classical Yasser-Gillian pterional. We have the supraorbital, now mini craniotomy that is very popular. And we have even an eyelid approach. And these have many advantages. The open approaches to anterior skull-base meningioma have many advantages. These are well-known traditional procedure. There's no need for a learning curve. We learn this as part of our training. It can deal with all sizes of tumor and all locations of tumor in the skull base. There's no issue with microscopic view, 3D. We have very good recognized reconstructive techniques with low rates of CSF. There's no issue of the nasal morbidity. And we have long-term follow-up of data that shows relatively acceptable results. But however, there are disadvantages, and we can't deny these disadvantages of the open approaches. First of all, there's many. So, why one over the other? There's no one perfect approach. There is an element of invasiveness with any craniotomy and a little bit of brain retraction. I don't care what anybody says. Even a mini craniotomy, you still need a degree of brain retraction and some degree of manipulation of neurovascular structures. But these are not that important. The issue is that there have been recognized complication rates with open approaches. And if you look at visual issues, this is an important one, up to 30% in some recent series of worsening of vision after an open approach, particularly for tuberculum meningiomas. And there's still some mortality. So the answer, at least the question, is really this: can the endoscopic approaches, these new approaches, address these concerns? And can they improve on this concern? Because if they can't improve on it, then there's no use for them. So if we look at the endoscopic approach, of course, if you go to meetings, you see the advantages, all the advantages that people talk about: more direct approach to the lesion, less invasive, no brain retraction, et cetera, good visualization, better access to the deep structures. And so these are many of the advantages, but we cannot also ignore that there are disadvantages. And these are some shown here. These are technically very challenging procedures. Complication management is also difficult. The whole issue of reconstruction of CSF leak, I'll show you. While we have made significant progress in the CSF leak, still this is not 100% solved. And then of course there's a learning curve. You cannot remove this tuberculum meningioma if you go to a course and then come back and do this. This requires training and to me a fellowship. We have people that come from all over the world in terms of to learn these techniques, but it takes a lot of training. There's certain prerequisite. If you want to do these expanded approaches to the skull base, you need to know anatomy, because anatomy is critical. It's a different anatomy from below. You need an interdisciplinary team of experienced endoscopic surgeons. I do these all with my experienced rhinologist, endoscopic rhinologist. We need a binostril, bimanual microsurgical technique, because as surgeons, we are not, one-handed animals. We need both hands. And of course, instrumentation is critical. And as I said, a learning curve. So anatomy, this is the anatomy we're looking at. Basically, they're all transnasal approaches. There's the transcellular, basically tubercular, transplanum, and transtribiform. This is anatomy from below. Here's the anatomy that you see from above. This is the area that we really are looking at. So this is the anatomy that we're looking at. the transcellular, transtubercular, and then transplantum approach, and then more forward, of course, it's a transcribiform approach. So it's really the same anatomy that we're looking at. We're just looking at it a different view. If you look at this is the view from below, looking at this area, and then the same view from above. So it's the same anatomy from a different perspective. Now, it's very important when we talk about anterior skull-based meningiomas and endoscopic approaches that we have to put things in perspective. If we look at the fact that skull-based meningiomas represent only about a quarter of all meningiomas, and anterior skull-based meningiomas are about 9% only. And then of these other ones that I don't think there's any role for the endoscopic approach, we're really left with really very few meningiomas. The olfactory groove planum and the suprasellar tuberculum cella, which really is about 6% of anterior skull-based meningiomas. So you have to understand that these are very uncommon lesions, and the average neurosurgeon is lucky if he sees 1 or 2 maybe a year. So we have to keep that in mind because this is not a common condition. This is our series now. If you look at, I showed you before, 500 cases, but if you look at meningiomas, 45 cases over the last 10 years. That's only 3 to 4 cases a year. So these are, again, that I've done, which are not that common. Of course, I've done open approaches, which I'll show you too. So let's get to the issue. 64-year-old gentleman. I'd been following him for 5 years with this because, initially he was asymptomatic. Then he had significant, he started having headaches and progressive growth. So can this be done endoscopically? The answer is yes. This is what we do. We go in using a basically transplantar, transcribiform approach. We do a craniectomy from below, and using the same techniques that we do, we can remove that tumor. And then basically this was then repaired, as you can see here, with a nasal septal flap shown here, all the way over to here. And this patient, as you can see, 7 hours, nasal septal flap reconstruction, no CSF leak, no cognitive deficit, loss of smell, 4 days. And this patient is now 5 years. You can see tumors all gone, no evidence of disease recurrence. What about this patient, 76 years of age? Can this be done endoscopically? Again, the answer is yes. This patient, as you can see here, we basically do the same. It's a microsurgical approach using a transcribiform approach, using the same instrumentation, Cavitron that you can see. You can use all the instruments. And ultimately, just as we take this out to show you, I don't want to waste a lot of the time. Here's after the removal of the tumor, and then a nasal fascia lata and nasal septal flap reconstruction. This patient, you can see postoperative, OR 7 hours, length of stay 5 days, no cognitive dysfunction. She's 76, no CSF leak, did have loss of smell, and 6 years, you can see no evidence of recurrence. Now, what about this smaller lesion? Nice, smaller tuberculum cella meningioma. You can see this is a doctor who presented with this visual dysfunction, in her right eye, as you can see, tuberculum cella meningioma. And all these approaches, doctors shop around. They never, so she went to many doctors and these were the approaches she was offered. People told her we could do a nice terional approach, semi-eyebrow, and then she came to me. And at that point, I must tell you, I had only done maybe 4 or 5 endoscopic approaches. So she is a doctor, and I had only done 4 or 5, and I had published on the open approach for tuberculum cella meningiomas in the British Journal of Neurosurgery. So what do you think I offered her? I said, no, I think an open approach is better. We have, we know the results of that, and I've done many and so forth. But she, as a doctor, did not want to have a craniotomy, did not want her brain to be, touched. So she wanted the endoscopic approach. I said, that's fine, as long as you understand this is a newer approach and so forth. Anyways, so this is what we do with this. This is a transcellular, transtubercular, transplantum approach, what we do. And then again, just because of time, I'm not going to bore you with the other thing, but this is the exposure ultimately. And this is what happened because we take the posterior ethmoidal vessels for these, so that the tumor is very often very avascular like this. And we wish all our meningiomas were like this. As we come over here, we can see now why she had an optic neuropathy on the right side, shown over here. And we do the technique is just using microsurgical technique. And there it is. There's why she had vision problems in the right eye. And then as we take this off using the same technique, and here we are after the removal. And this is after the removal that we see. This patient was repaired with a multi-layer fashion and with a nasal septal flap. And this patient is now 2 months. Here she is 7 years after the procedure. Now, as I said, I'm not going to go and show you another 10 videos, but to show you, these are the procedures that some of them done 1 year, 4 years, 5 years. I showed you this, 6 years. This patient is 10 years after, and this is our longest patient, 12 years after this removal. You can see no evidence of disease recurrence. But we learn some lessons. And as you go on and do your thing, you must always learn. You must learn from your mistakes. You must learn from your things. So we learned a lesson. So we had this patient that came 75. She was elderly. I wanted to consider an endoscopic approach. And she had severe visual disturbance, almost blind, finger counting on the right. What approach? Open, endoscopic? Well, to me, no, this was not. We learned a good approach for an endoscopic approach. Look at the encasement of the anterior cerebral vessel, and you can see it going here. This would be very difficult to dissect going blindly from below. So this patient, I learned that this is not a good technique for the endoscopic approach, and I did this and also the carotid encasement, I was going to say. Then we did this using my open approach, which I generally like to do, is an interhemispheric, what I call transbasal approach. And you can see here what we do, dissecting the interhemispheric fissure, and then we come down and using microsurgical technique. And here's after the removal. You can see the pituitary stalk, and then this we brought in the endoscope to show the ability to spare the olfactory nerves that you can see here. This is patient, you see 8 years after surgery, no evidence of disease recurrence. This is another lesson we learned. This is a 44-year-old patient, headache, memory issues. On examination, she was normal. Can this be done endoscopically? And the answer is yes. But should it be done endoscopically? And for me, now it's no. You say, why? Well, she has normal smell. Now, we take olfaction for granted, as neurosurgeons, we do operations, but olfaction, as I learned from my colleague, ENT colleagues, a very important function to lose olfaction. So all endoscopic approaches for these procedures results in a loss of smell, loss of function. And so to me now, 10 years ago, I would have done this endoscopically. Now I don't. Now we'll do this open, and that's we did it using an interhemispheric transbasal approach. We were able to spare one olfactory nerve, because you do know that even in the open approaches, you don't always spare the olfactory nerves, but you have at least an opportunity, a better opportunity in the open approaches than the endoscopic approaches. So you can see this patient here. We spared this olfactory nerve, OR 5 hours. She had retained smell in that one eye, then to stay 5 days for postoperative visit. What about this patient? We learned some lessons. Well, we learned this is a 37-year-old female, again, visual problems of this tuberculum cell meningioma. And again, can it be done endoscopically? Yes, but should it be done? Again, for me, no. I've learned why. The carotid encasement. Once the meningioma goes lateral to the carotid, it's very difficult. Occasionally, if you've got a very nice arachnoidal plane, you can pull things out, but you can't always do that. And if it's encased the carotid, it's not. The other thing that the patient also has evidence of canal invasion, optic canal invasion, and we know that lateral extension, particularly in the optic canal, is not good for endoscopic and this carotid encasement. So this patient, as you can see, I did using a terional approach, a nice right terional. You can see drilling down the clinoid. Very nice decompression of the optic nerve that you see here, And this patient, as you can see, improvement in his vision at 4 weeks, significant improvement in his vision. Now, can this be done endoscopically? Well, I think everybody here would pretty well agree that this definitely not. This has all, for me, the characteristics that is not good for an endoscopic approach. Everything that I've showed you, carotid, this vessel encasement, significant lateral extension. You will never be able to get a dural margin on using an endoscopic approach. Anterior extension to the frontal sinus. That's going to be very difficult to get a dural margin there. So definitely not. And again, this patient I did using an interhemispheric approach. You can see beautiful resector. You're able to drill down the inostosis. Postoperative MRI, you can see here. And again, the open approaches, just like I showed you for the endoscopic approaches, they have longevity. This one is 6 years with this laterally. This one here is the extension over the carotid, 8 years. And this one is 10 years. This large one that I just showed you now. This one is another 10 years. You can see right pterional approaches and so forth. So my current indications, or what I call favorable characteristics for the endoscopic approach for anterior skull meningiomas are these. The small meningiomas, midline with minimal lateral extension, no vascular encasement, no significant optic canal extension, minimal peritumoral edema. In elderly patients where the aim of surgery is only debulking, you're not trying to get a Simpson grade 1 removal, and patients with a preoperative loss of smell. They already have loss of smell. The limitations or the contraindication are the opposite of these larger tumor. So now the question that comes up, people, I would say here now, given that I've told you from the beginning that there's only very few of these to begin with, a year, and now all the contraindication limitation I just showed you there, the argument is, why bother? Is it really worth it for those few? What are the real advantages of the endoscopic approach? Is it less brain retraction, better neuropsychological sequelae, quality of life? Is it better visual outcomes? Is it less complications? What are the disadvantages? Increased CSF leak rates, incomplete tumor removal with increased risk of recurrences. So do we have any data here? Is there really any data that can answer these questions? Because we have to have answer to these questions before we can say one or the other. So let's look at less brain retraction and neuropsychological sequelae. So this patient is 88 years of age, bilateral severe visual dysfunction. Does the endoscopic approach offer advantages to this patient? In my mind, the answer is yes. The aim here is not to get a Simpson grade 1 removal. It's not necessary because of her age, and it's, but the key here is to decompress her optic nerves. And the endoscopic approach can do this nicely. And you can see here what we did with decompress her optic nerves. We left some tumor laterally, as I expected. And this patient had improvement of her vision. As you can see here, no cognitive deficit, was home in 7 days. So to me, for this particular type of situation, in a very elderly patient with the aim is just to decompress the optic apparatus, I think it offers an advantage. And there's been some studies, but showing neuropsychological, that there's suggestion that better intelligence score or after endoscopic, but this is not, I cannot say the literature is definitive on that. What about visual outcomes? Well, I think this is a patient that you can see here, 58-year-old left-sided visual disturbance, done using an open approaches. Now, all open approaches, it doesn't matter what you use, but there's always an element of some degree of retraction of the optic nerve. It doesn't matter how careful you are. These are, as you can see, this is down beneath there, and as careful as you are, there's always going to be a degree of retraction on the optic nerve, and particularly if that optic nerve is very tenuous, it's a significant visual disturbance, you're going to potentially injure that optic nerve. This is why when I showed you before the complication rates, visual outcomes, that's why we do get a series where there's higher rates of visual dysfunction. And I'm not going to bother. In the end, you can get a nice resection, but there has been a degree of manipulation of the optic nerve. And this patient, as you can see here, vision improved, no neurological deficit, and here's a nice MRI scan. But look at this patient, very similar, an endoscopic approach. This is on the other side. The difference with regard to the optic nerve and optic chiasm, there's no manipulation of the optic apparatus using this approach. You can see, as you can see here, there's the superior apophyseal vessels to the stalk, to the chiasm. And look at this nerve. This nerve was almost eroded through by the tumor and the A1. So this is a very vulnerable nerve. Even just looking at this nerve would possibly give you a worsening of vision. And you do not touch the optic nerve, and you spare the optic blood supply. So this patient, you can see 2200 to 2020, no visual deficit, rest examination normal. Here's this patient now post-operative, again showing no evidence of disease and nothing in the brain, basically no flare change in the brain. So if we look in the literature, and this is a variety of meta-analysis and systemic reviews have been done looking at tuberculum meningioma between microsurgery and endoscopy. Generally, the results suggest better outcomes with vision with the endoscopic approach and less worsening of vision in the endoscopic approach. And if you look again in the literature, many reviews of looking tuberculum meningioma versus open approaches. But I have to say that we have to be careful here when we look at systemic reviews and meta-analysis. And this is for the younger people that are looking at here. You have to be very critical because often these are unreliable. If you look at sometimes the case selection bias, so many of these have a group, olfactory groove, planum, tuberculum, all in one group. And these are very different entities. And some of the numbers are significantly greater in the open approaches. There's longer follow-up, and the data reporting is not uniform. So the size may be different, whatever. So you have to, again, be very, very careful. So this is a series that Ted Schwartz from the Cornell put out. And what they did, which is very interesting idea, to look at a similar cohorts of patients. So these are patients that both open endoscopic surgeons looked at and said, yeah, this can be done endoscopic and it can be done open. So they're smaller sizes and so forth. And they have, as you can see, and they, looking at here in terms of visual outcome, much significantly better. Now I have colleagues who criticize this paper. They cannot believe this. It's how can, they said the open people don't know how to operate because, how can you get, 40% worsening? But this is the reality out in the literature. So significantly better outcomes in terms of vision with the endoscopic approach. What about CSF leaks? Well, this is to me, something that has improved. And I tell people that when I started with the open approaches, in skull-based surgery, we had high CSF leaks also, 30% when I started back in 1980 using craniofacial resections. And the CSF leak rates in the endoscopic, of course, has come down now to a more acceptable level. Still not 100% resolved to me. Still an issue, but at least it's now more acceptable. Finally, incomplete tumor removal with increased recurrence rates. Well, this is again a systemic review based on early on of 75 series. Here, there is no real difference between open endoscopic approaches for the tuberculum cellular meningiomas. This is tuberculum cellular meningiomas is our group, my group that reported this, looking at open and endoscopic, and there was slightly, definitely higher total removal rates in the open approaches than in the endoscopic approaches. And I think this is again, if you look at Ted Schwartz, he has about the same. So we looked at our series. This is a series of anterior skull-based meningioma after endoscopic removal, a 10-year experience in 52 endoscopic and transcranial. So we looked at 26 open and 26 endoscopic tuberculum cellular olfactory groove. And this is our overall results were better increased growth hormone rates in the open approaches over the endoscopic approaches. CSF leaks, as you can see here, was not statistically significant, but recurrence rates also a higher tendency in the endoscopic approach, but not reaching statistical significance. So we come to the question now, is there any role for the endoscopic approach? Yes, no. A randomized trial would be good, wouldn't it? But I can tell you it will never happen in this. First of all, they're too small, series in terms of these are not common, so it'll only have to happen. So how else can we do it? Well, now there is consensus statement. And recently there's been published, and you can look at this, the International Forum Allergy, looking at, it's a first international consensus statement on endoscopic skull base surgery using evidence-based review and recommendation using the Redneck protocol. So what we do in this, and I was asked to do the olfactory group meningioma, is we do a systemic review of the literature following PRISMA guidelines. All the database are reviewed. Then we look at level of evidence from A, which is a well-designed randomized controlled trial, to a randomized controlled trial with limitation, observational studies, case control, and then expert opinion. And then based on this, we give a grade of recommendation. So a strong recommendation that this is the way you should be doing, or a strong recommendation against what you should be doing, and others that are optional. And I can say, I mean, everybody knows there's no grade 1 randomized trials in this subject. So we were asked to do olfactory groove meningiomas, and this is what we found. Basically, one of my fellow was there, Ahmed Al-Sawi, who's from Egypt. We found that basically the case selection bias, as I mentioned before, non-independent reference standard and no sensitivity analysis limit really any accurate attempts to compare transcranial with endoscopic for olfactory groove meningiomas. And that in spite of increasing experience with the endoscopic approach, the extent of resection is still inferior to the transcranial approaches, and the CSF leaks remain higher. And there is, in addition, the loss of olfaction is significantly higher in the endoscopic approach. So my conclusion from this was that there is currently no hard data showing a value add or superiority of the endoscopic approach over open approaches. So our recommendation was basically on evidence C and recommendation level 4 about optional. So if you do a good open approach for for a olfactory meningioma, you're happy with your results, keep doing it open. For those of us that do endoscopic approach, we see a patient with a loss of smell, a nice smaller lesion that I can get it, I will continue to do it using an endoscopic approach. Tuberculous cell meningiomas. Again, it was very similar. It's very difficult to compare because of all the issues of, but we did note that with careful patient selection, the endoscopic approach can result in equivalent gross total removal rates as the open approaches with better overall visual outcomes. While the CSF leak remains higher with improved reconstruct techniques, including nasoseptal flaps, the rates are approaching acceptable levels. So my feeling is that the extended endoscopic approach will likely become the preferred surgical approach, but for a very select population of smaller midline lesions. So again, this is optional. So as I get to the end, this is a Scott's parabola. Those of you may know about this. Scott's parabola is a parabola of the new surgical interventions that come up, new innovations. So where is endoscopic skull base surgery? And this is I did with Capabianca and Nikolai. I did an editorial looking at this. And the issue is, is it going to go with some procedures that have come with incredible promise? This was going to be changing to finally fall off the cliff to the other side, that they were very, in the end, not any better than the existing and even worse. So some people would suggest that the endoscopic approach for anterior skull base meningioma is going to have the same thing. I don't agree. I think that the endoscopic approach is an approach that's here to stay for anterior skull base meningioma, and that we are still in the era of carefully having selected, carefully selecting patients, and a small cohort will be benefited by this approach. So in conclusion, I say in the absence of any high quality evidence in the literature and unlikelihood of randomized control studies, we need analysis of larger prospective series of patients with longer follow-up to evaluate the rates of the gross total removal rates, complication rates, and incidence of recurrence. I believe that traditional open surgical techniques currently remain the gold standard and the approach of choice for the majority of anterior skull base meningiomas, for the majority of neurosurgeons. Neurosurgeons caring for patients with anterior skull-base meningioma should be prepared to offer the patient an approach that is based on current available evidence, the neuroanatomical features of the tumor, patient input, and very important, the surgeon's own experience with the technique, rather than just a bias of saying against one or other technique. So this is my last slide. This is a patient, a 64-year-old patient, and when I present these to an audience, I will say, okay, here's a patient with this tumor. How would you do it? And I have a show of hands going up and down. Well, for me, this has the features that I can do with an endoscopic approach. Small lesion, not laterally, midline, not into the optic canal. And as you can see, this patient, we did an endoscopic, expanded endoscopic approach, and we're using a microsurgical technique as we take that off. And I showed you this before, and I won't bore you. Ultimately, to get a nice removal of the tumor, you can see beautiful sparing of the superior popliteal vessels to the chiasm to the pituitary stalk. 6 months out, you can see a nice removal, improvement in vision. So the evolution of skull-base surgery, quo vadis, open. If you go to meetings now, there's always the issue of versus, and I think controversy to say is nice, but I think we're beyond now the issue of open versus. We are more into and, that they're complementary. And I think, open and minimally invasive endoscopic techniques, I think for the young people who are interested, has a bright future for skull-base surgery. So thank you very much for your attention. I'm happy to any questions that might be.
Yes. Thank you, Fred. Thank you for this outstanding presentation. Professor Bouyousef. Professor Bouyousef, I think he has a lot of problem of connection.
Yes.
Activez votre micro. Voilà.
I have a great problem with my connection. I lost half of the conference. C'est dommage.
I ask you to begin the discussion with the panelists. Professor Bouaita is with us. He joined.
I am here.
He's here.
Professor Bakhti, thank you, Monsieur Fred, for excellent presentation. I am Professor Bouaita, head of Department of Neurosurgery in Algeria. I do several endoscopic approach, like anterior fossa, pituitary adenoma, craniopharyngioma, and posterior fossa. I have 3 questions for you.
Yes.
Number 1, what is your experience with esthesioneuroblastoma with endocranial extension?
Okay, so this is a esthesioneuroblastoma.
Yeah.
Right.
Yeah.
So esthesioneuroblastoma, I do both endoscopic and open. And the criteria is not intracranial extension, is lateral extension. I have to be able to get a free margin. As you know, this is a cancer. So if I believe that I can get a free margin with an endoscopic approach, I will do this endoscopically with my ENT colleague. It doesn't matter if it's gone through the, into intradural. I'll still do that.
Yeah.
If it's gone laterally, I see the dura over that I cannot get a free margin, I will then do this open.
Okay. My second question, in case of extension of the meningioma, tubercle meningioma toward the optical canal, do you operate your patient with endoscopic approach?
Yes. Now that's a lot of, it's a big controversy, as you know. I agree with the endoscopist that if the extension is strictly medial, in the medial canal, that this can be done endoscopically, because it's like doing a optic nerve decompression for thyroid toxicosis. You remove the optic canal medially. So that, I think, you have to do very carefully look at the preoperative MRI to see that it's just a medial extension, can still be done endoscopically. And we do that because we do basically orbital tumors, medial orbital tumors, we do endoscopy. But any evidence that it goes laterally around, then it's impossible to endoscopically, and I will do that open.
Thank you. My second question, do you always operate now, or operate the small olfactory meningioma endoscopically?
I say my indication is if it's small, if it's midline, smell is gone, endoscopically. Otherwise, if they still have a smell, I will go from above because I want to try to spare their olfaction.
Thank you, Monsieur Fred.
Monsieur Bouyoussef, activez votre micro, s'il vous plaît. Activez votre micro. Voilà.
Je n'entends rien, je ne vois rien. Dans la majorité des cas, I have problem with my connection.
Non, non, on vous voit et on vous entend.
Mais maintenant,
Ouais.
maintenant,
Ouais.
Voilà, vous pouvez dire.
ça revient.
Voilà. Ben, je vous laisse le soin de continuer la discussion avec nos autres panélistes.
Bien sûr, je voudrais donner la parole au professeur Abdessamad El-Wahabi qui est avec nous.
Merci. Thank you.
My dear friend, have you some comment?
Okay, thank you. Thank you, Khairuddin. Thank you, Suad. Thank you for the Algerian Society and the Maghreban Federation for organizing such a meeting. And thank you for Fred. And I attended many of your conferences, and this is one of the most controversial issue is to treat skull-base meningioma endoscopically or by microsurgery. And my comment is, I have a comment and a question. My comment is that thank you for presenting this very difficult field in the well-balanced way, mainly for a surgeon, because as you said, it's not just a matter of pictures and a very good video. It is very important to see the results of that and also to see the complication. So it's very important. And also the way you present your conference, that means endoscopy is not the solution for every case of meningioma. This is true, that's for sure. My question is, in your practice, do you discuss with the patient to contribute or for the choice of the operating approach? Did you get my answer, my question, Fred?
Yes, I did. And
did you get my?
Yes, can you hear me?
Did you get my question?
Yes, I got your question. Can you hear me? Yes.
Yes.
Can you hear me? Yes. Yeah. So I got your question, and this is a very interesting situation because I always discuss with my patients, and they are sent to me by other neurosurgeons saying, to do it this way because you want it this way. And I discuss always with the patient, but you have to be very careful with the patient because you can make a patient do whatever you want. If you how you present it, because it's through the nose, it's so easy, you don't touch your brain, and it's everything should be done endoscopically. So I am very careful to go with the patient to explain that there are advantages, of course, but there are also disadvantages. So yes, I go very carefully with the patient. And in the end, I will say, these are the two options. And then of course, the patient will say, well, doctor, you're the expert, you decide in the end. And I will, and I will base it on what I showed you today. If I think, they come to me expecting me to do it through the nose because they said, oh, I want, through the nose. I said, but I'm sorry, this is not a good one for the nose. And I will, will say that this is not one, even though you were sent me to do an endoscopic approach, I do not recommend an endoscopic approach. So you have to be very honest with the patients. Okay.
I think, Professor Youssef, do you hear us? Yes, because, yes, I think we can continue with Professor Mehdi Darmour from Tunisia.
Yes, please, Professor Darmour. Is my friend Mohammed Salehi here with us?
I don't think
Mauritania?
Suad,
No?
I'm sorry, but there is no option for have a hand level. I can have some question.
Yes, but before we have to ask Professor Darmour, and it will be, it will be you.
Just to know that I'm waiting. Okay.
Thank you very much, Professor Bouyoussef. First of all, I would like to thank Professor Bakhti for her invitation. It's an honor and a pleasure for me to participate to this webinar. I thank also Professor Gentili from Canada for his excellent conference with good videos. I think that endoscopic extended approaches are a good alternative and an addition for the surgery of some anterior skull-base meningioma and for some selected cases. This technique needs great experience for having good results. For my side in Tunisia, and especially in, at least in my department in Monastir, we still did traditional transcranial approaches for anterior skull-base meningioma, pterional or bifrontal, depending on the extension and the exact location of the meningioma. We have not experience in endoscopic approach for this kind of meningioma. We did the endoscopic approach only for pituitary, for cellular and supracellular pathology. And thank you very much for this excellent conference. Thank you.
Alors,
excellent. Najia, do you want to have a comment?
Najia.
Yes, please. Thank you, Suad, for this excellent webinar. Really terrific, and with our famous guest, Fred. Thank you for this outstanding talk. And my question, and many times when we met, I always ask you about this special meningioma in this area, especially for the anterior skull base. And we know, I know you are the master in this field. So you have, of course, you didn't have, or don't have a lot of, CSF leg. But what can you give us for, especially for the younger neurosurgeon, that they have to start with this endoscopic approach? What's the tricks and tips for avoiding these complications? Thank you, Fred.
No, not at all, Naja. So the first thing that I say, you must, before you even consider doing an extended approach, you must become very proficient with doing a good pituitary surgery.
Sure.
Okay, pituitary surgery. Some people ask, well, okay, how many should I do before I can, should do expanded? And some people, the Pittsburgh group will say, you got to do 50 or 60, some people 70, then you can go to expanded. So I think the key, very important, however, to get very proficient with a good pituitary endoscopy. Now, in terms of CSF leak, as I said before, people will tell you, oh, we've solved this now. In endoscopy, no more worries. That is not true. There's still a problem. what you need to do is a few things. The repair is very crucial. And another thing. So the repair, I use a very multi-layer repair with a biological material. That means fascia lata. I do not use any synthetic things. I think you need biological material. So I used fascia lata in fat, multi-layer inlay fascia lata, onlay fascia lata. Then the nasal septal flap is very crucial. And then tissue adhesive. The other thing that we're learning now, more and more, we used to basically keep these patients flat, say keep them down for 48, 72 hours. Mistake. Do not do this. We've learned from this issue that the mobilizing these patients early is actually better because it's a common sense. You've got less ICP pressure when you're up than when you're down. So, we now we'll in bed, keep them at 15 to 30 degrees immediately after the surgery. Then, get them up within 24 hours, 48 hours. And so the combination of a good repair plus this early mobilization, I think has significantly helped us to reduce the CSF leak rates. In our series, it's down about 7%. That's still, we can say pretty high, but at least it's down in below 10%.
Okay, so I will ask you the question, but what, in your opinion, when you did maybe more than 60 with 70 pituitary adenoma by endoscopy, you can start, but I have more than 100, but I'm afraid when I think about go to the jugum meningioma or anterior meningioma. The step to go out to the extended is not easy that we can when you start to go to endoscopy. Sure that when you start endoscopy when you switch from the microscope to endoscopy is a step very, very special, but go to extended, it's all also not easy. It's a difficult step, and the beginners for these steps, what's your advice?
So again, Nadia, I think maybe before everybody.
Do you get my?
Yeah, I think I heard it. Everybody would agree that while there's a lot of controversy with meningiomas, there's not as much controversy with craniopharyngioma. Most people now are in agreement that the endoscopic approach is probably the better approach. So start with the craniopharyngioma. Do the little exposure that you can do your craniopharyngioma, and then gradually, it's a matter of gradually, you come a little bit more anterior to do the planum and so forth. So my issue is always that. It should be a graded level of improvement. You can't go, that's why I say you can't go and never have done a meningioma and then suddenly remove a large planum meningioma. So to me, it's a great graduated thing. Start with the pituitary, start with then giant pituitary. Get where you have to go a little bit more. So do a little bit of exposure more anteriorly to the planum to do a giant pituitaries, then a craniopharyngioma, and eventually, slowly, it comes. There's no magic. There's no magic rules, unfortunately.
Yeah, sure. Yeah. Sure. Okay, thank you, Fred. Thank you very much for this really amazing talk and all the advice that you can give us. Thank you.
Thank you. No, my pleasure. My pleasure, Nadia.
Okay.
Professor Bouyousef.
Any more comment or question?
Yes. Yes, we have question. Yes, hello, Nabila.
Yes. So the first question is about carotid artery. He's asking about this carotid artery. If you had an injury, and what about pseudoaneurysm?
Okay, people ask me all this, and I always tell them, fortunately, and I always touch wood, that I have not had a carotid injury. Now, I don't know what that means. Maybe I'm not aggressive enough, but I think you have to be aware, the awareness of the carotid injuries, you know, that you have to be very careful. So I have not. I'm aware of the anatomy. You have to always be aware of the anatomy of where the carotid artery is medially, particularly medial OCR. That's where most of the injuries occur. You know, where the carotid artery goes intradural. It's called the medial OCR. So you have to be careful. I use Doppler ultrasound all the time. So I know and I can feel, you know, can hear where the carotid artery is and so forth. And so anatomy, understanding the anatomy is very important, using Doppler, ultrasound, image guidance. Now, as I say, I've not had a carotid injury, but this, as you know, it happens, particularly, you know, in terms of so how do you manage it? Well, as soon as you feel you've had a carotid artery, pack, stop the bleeding, you know, by putting packing immediately to the interventional neuroradiology for an angiogram, and then they will see what's happening there, whether they've got a pseudoaneurysm, whether they've got you know, something there, and to treat it using interventional techniques. The key is, if you don't see anything immediately, I always repeat the angiogram 1 week before they discharge, because sometimes a pseudoaneurysm can be delayed and not picked up, you know, on the first angiogram, but be 10 days later it can show up. So always repeat the angiogram.
Thank you.
I think
another question.
Yes, you know,
from Professor Sisaber. So he's asking about the learning curve, which is important. So from how many cases we could speak of a safe learning curve in practice?
Yeah, that's a good question. And there really is not a hard number. That's why I said, in terms of, you know, learning curve from pituitary to, you know, craniopharyngeal to meningiomas, you know, there's numbers that people have thrown out, you know, if you get to 50, 60, 70 pituitaries and so forth. But, you know, to me, it's sometimes different for every person. You know, some people need 100 before they feel comfortable. And I think it's what you're comfortable with in terms of, as you do these and you improve. So I'm sorry, I can't give you a magical number to say, you know, after you've done, you know, 50 pituitaries, now you can remove your, you know, meningioma. It's an individual situation in terms of learning curve. But for the young people, I think you really need a training in this. And courses are very important, of course, and I teach in many courses, but you need training, and I recommend for the younger people to do fellowship in endoscopic and open skull-based surgery. Our fellowship, the advantage of our fellowship is that, you know, you go to a fellowship, whether it's Pittsburgh or something, all you do is endoscopy. It's endoscopy, 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 and that's, you know, ours, we do open and endoscopic. So they learn just what I showed in my lecture today, that there are those that, yes, endoscopy is very good, but there are others that not, you got to do open. So I think it's important to have training where you are able to see both.
Thank you.
We have also, yes, we have a comment from the floor from a colleague from Lagos in Nigeria, and he said that he would like to take esthesioneuroblastoma intranasally. What do you think about that?
Esthesioneuroblastoma?
Yes, esthesioneuroblastoma.
Yeah, I mentioned that with the other question. And esthesioneuroblastoma, yes, can be a very good tumor for endoscopic techniques, but you have to be very careful in the selection, just the way you do for meningiomas. If the esthesioneuroblastoma extends laterally over the orbital roof, then you cannot do it endoscopically because you cannot get clear margins. Esthesioneuroblastoma is like a cancer, and you have to do it using the cancer techniques of free margins. So that's how I determine whether I can do it endoscopically or not. I look at the MRI scan and look and I say, yes, I think I can remove the thing and get a free margin. If I feel I cannot get a free margin, then I do it open and get my margins from above. But some of them, the smaller ones, the midline ones, are very good for the endoscopic approach.
Thank you. Professor Bouyousef, is there anything to add from the panelists?
To add?
Yes.
Yes, I want just to ask Fred. Fred, why do you work all your cases with rhinologists? Do you think that it's mandatory? I tried with our otorhinolaryngologist in the hospital for the 10 first cases, and she was very, I should say, not very quick. So I just worked with the resident. By then he become like a surgeon assistant. And why your experience? Why do you still rely on rhinologists?
Okay, no, I think that's a good question. And as I told you, I do not use ENT for pituitary. So I can do a beautiful pituitary myself and so forth. For the expanded approaches with, with whether it's a transpterygoid approach, whether it's and it has to do, of course, who your team is. We've had, from when we did our open approaches, extremely good relationship with our ENT. And so we have a very close relationship. We work together and it works very well. And they refer these esthesioneuroblastoma we never see, they come from them. The angiofibromas, I don't, see those, they see it. So it actually works very well in terms of referring cases to each other. But I agree with you, it has to be, you have to find someone who is of interest. Can you do it alone? Of course, it can be done alone. If you do it, yourself, you get experience with it and you do it. And, could I do those expanded approach alone? Probably yes. But then why? Then they go to them for the rhinology issue. They clean up the nose and that. I don't have to worry about that follow-up. So there's many reasons, as you know, why we go it. First of all, a good relationship, working relationship. Then the post-operative follow-up in these can be very, significant in terms of nasal morbidity. So for those reasons, I do it. But as I say, not the pituitary. These are the expanded approaches.
Okay, thanks.
I think that the most important advantage of endoscopic of this kind of tumors is first to go directly to the feeding arteries in the midline, and it takes the tumor less hemorrhagic. And also we are far from the optic pathways and laterally to the vascular structures, especially the carotid. We have experience with this kind of tumors since a long time. And I think that for the meningioma of the middle line is the best indication is endoscopy. For lateral is different. We can, at this time, for the clinoid is very different. But from the middle line, I think that the endoscopy is the best way to remove this kind of tumors. What do you think?
Well, I think, Professor, you did very much my presentation was really that, small lesions, midline lesions, not so much lateral extension. These are the best ones for endoscopy. And I agree with you. You showed you that some of my video, the tumor was white, was avascular because I had taken the dural supply and the ethmoidal supply, the posterior ethmoidal and anterior ethmoidal. So you take the supply, I agree, you can take supply early on in these. So that has an advantage.
Monsieur Bouyousef.
Any more comment or question?
J'ai une question, Monsieur Bouyousef.
Nabila?
Professeur Bouaïta qui a une question. There's another question from Professor Waita.
Je peux poser la question?
Yeah, of course. Yes, you can.
Mr. Gentile, what is the right of the CCF leak after surgery of tubercular meningioma?
So again, you have to look at the literature and a variety, but they vary now. They started early on very high, maybe 50%, 60%, down to 30. For now, I think the majority, if you look in the literature, is less than 10%. Some people would say, and if you look at Schwartz's theory, 0. I don't believe this. I cannot believe 0. That doesn't, to me, it's impossible. But I don't think it's 0. Our own series is now, we're down at about 7%. Which is pretty good, but it's still 7%. So that's the roughly now, with the technique that we use, that I showed you, that I mentioned, plus the getting them mobilized quickly, we're down to about 7%.
I have another question. Use the vascular microdoppler in surgery? The vascular microdoppler.
The Doppler.
Yes.
Yeah, very important. I say you must use a Doppler for the carotid artery. So we use this all the time because it's important for carotid injury to know where the carotid is. And so we use a carotid Doppler routinely.
Yes. Thank you.
There is another question from Professor Sisaber. So some authors allow themselves to place clips to treat aneurysm. What do you think about that?
I think it's crazy. What can I say? This was, presented initially from the Pittsburgh group, and there are maybe the odd aneurysm, the carotid ophthalmic that goes medially would be a beautiful thing. But what if it bursts? No control, no ability to control. So I think this is something that you'd like to maybe do for a nice case review to show that it can be done. But just because something can be done does not mean it's right. So for aneurysm, absolutely not. And besides, those can be done very beautifully coiling. You don't need surgery for those at all.
Thank you.
So there are many, I was going to say there's many other type of meningioma. I didn't, my talk was of course only anterior skull base, but there's a clival meningioma that some people say should be done. And I've done virtually one clival meningioma because again, those have to be really midline, not go laterally. So to me, the indication for meningioma of the skull base really are the tuberculum sella, the midline, planum, olfactory groove, not so many other indication.
Concerning the CSF leak in our department, we have a trick. When we put the nasoseptal flap and the fascia lata and the fat, we push a balloon, urinary balloon. This balloon is swollen, and we take it 48 hours. I think it's good trick to maintain the pressure in the anterior skull base.
Yeah.
What do you think about that?
I think that was the original thing from the Pittsburgh group, from Min Kassam. They use this technique, and we use it. We also use it sometimes. The concern with that, people suggest that is sometimes depending the balloon. If the balloon is perfect, but if it doesn't, it can pull down the nasal septal flap. So you have to be careful. That I think it's a good idea, but you have to be careful it does not displace the nasal septal flap. The other thing that we do, you can do a balloon and then packing. You can do Xerofoam, Vaseline packing around. That's another way to keep the things pressure on the repair. Yeah.
Yes. Nabila, other question from the floor?
No, right now there is no other question.
Okay, over there it's now what is it? 10:30 over there. I think it's time.
Thank you very much, Professor Fred Gentili. It was a very, very nice webinar. And
thank you. My
yes.
pleasure. My pleasure. We'll see you again when we finish this COVID. We will see each other together and we can hug each other.
Bye-bye.
Okay.
Inshallah.
Inshallah. Ciao.
Yes.
Au revoir. Au
Thank
revoir.
you, Fred.
Suad, do you have some
Some
words to conclusion?
Pardon?
Thank you very much.
Just
Okay.
thank you so much to Fred and to all the panelists from Morocco, Tunisia, Algeria, and all the participants. We have had participants from Mexico, from Rwanda, from Nigeria, from Congo, from everywhere in the world. So thank you to all of you, and hope to see you next week in the next webinar of the Algerian Society. Thank you so
Very
much.
good. Bye-bye, everyone. Thank you.
Bye.
My honor. Bye-bye. Bye.
Bye.
Bye-bye.
Bye.
C'est bon?
Oui, c'est bon. Merci à tout le monde.
Bonsoir, bonsoir, c'était très bien.
Écoute, c'est dommage, moi j'ai raté une grosse partie de la conférence.
Monsieur Bouyoussef, on vous envoie le lien sur YouTube.
Il y a YouTube, on a la chaîne.
C'était très bien, très bien.
Vous pourrez
Bravo.
suivre, il n'y a pas de problème.
D'accord.
Bravo.
Ouais, on vous donnera le lien. De toutes les façons, tous les webinaires, ils sont enregistrés sur la chaîne de la Société.
Oui.
Très bien.
D'accord.
Voilà.
C'est Abdel Samad, ça m'a été un plaisir de te revoir.
Oui. Bonsoir, bonsoir tout le monde.
Tu m'entends pas?
Monsieur Ouamou.
Allez, bye bye.
Monsieur Ouamou, merci. Merci d'être venu.
Abdullah.
Bye, Kamel. Ciao, merci beaucoup.
Bye bye, Monsieur Bouyoussef. Bye bye.
Ah, Monsieur Abdenbi.
À très bientôt.
Merci,
J'ai
Monsieur
pas vu
Abdenbi.
Hafed aussi. Il y a Hafed
Il
Jebel
est où?
aussi.
Je ne l'ai pas vu, Hafed.
Je viens de voir Hafed.
Ah ben, je ne
Tu
savais
nous
pas
entends?
qu'il était là.
Salut les amis, très bonne soirée, c'était super.
Très bonne soirée.
Salam alaikum.
Najia, très bonne soirée.
Salut Abdou.
Bonne soirée.
Très bonne soirée tout le monde. Je vous
Et
embrasse
bravo,
tous.
bravo, c'était une
Salam
réussite ce webinaire. Ça,
Bravo.
Bravo.
Allez. Merci à tout le monde.
Je vous embrasse tous et bon courage.
Monsieur Abdenbi, bye bye, bonne nuit.
Nadia.
Oui?
Nadia.
Oui, oui, je t'écoute.
Nadia.
Je t'écoute,
Mabrouk
Khaldi,
Alina.
je t'écoute. Et ouais, c'est la
Mabrouk
petite-
Alina.
c'est juste une petite étape.
قلت لك
Faut
مبروك
attendre
علينا.
الله يبارك فيك ولكن عاد غنبداو le vrai travail maintenant.
لا
guerre
جيبوها
va commencer
جيبوها ان شاء الله.
Et je compte sur l'aide de tous mes amis et tous nos amis,
نجيبوها ان شاء
Inch'Allah, pour
الله.
qu'on puisse réussir peut-être enfin cet exploit. Inch'Allah. Inch'Allah.
Voilà.
Merci à tous. Merci à
Ciao.
tous pour vos encouragements.
Merci. Au revoir.
Je vous embrasse très fort. Au revoir.
Bonne soirée tout le monde.
Au revoir, c'est
Allez,
Abdullah.
Abdullah,
Oui, oui,
je
salut.
t'appelle.
Avec plaisir. Avec plaisir.
Bonsoir, c'est à moi. Au revoir. Soso.
Bisous à tous. Au revoir. Au revoir.
Nabila, tabarakallah alik. Bravo, Alik. Hein? Vraiment.
Il n'y a pas de problème, c'est toujours un plaisir.
C'est Abdenbi.
Ça va, tout va très bien.
Ça fait, allez.
C'est bon.
C'est bon, j'éteins?
2 secondes, ça y est, j'ai répondu à Bourklif.
Ah, d'accord, oui.
Voilà.
La semaine prochaine.
Voilà.
D'accord.
Allez.
Donc, allez.
Allez, on y va.
Attends.
Quoi, qu'est-ce qu'il y a?
Souad?
Oui, donc on se voit sur WhatsApp.
D'accord. Ah, ok, on switch sur. Ok.
Voilà, on switch sur WhatsApp.
Vous pouvez rester comme ça, je suis en train de...
Très bonne soirée.
Ah, tu es en train de... Alors, d'accord, si tu peux fermer les...
Vous pouvez rester, il n'y a pas de problème.
Il n'y a plus personne, t'es sûr?
Non, un moment. Ah,
attends,
oui.
si, il y a encore Jamila, il y a Ajdan.
Arrêtez la diffusion sur
Il y a du
YouTube.
monde. Et puis, et YouTube, hein, t'arrêtes YouTube aussi.
Ah, okay. C'est bon, j'ai arrêté YouTube, je suis en train de...
Mais c'est encore en live sur YouTube.
Non, je viens de...
C'est marqué. Marqué live sur YouTube.
Il y a Jamila qui est encore branchée.
Il y a Jamila qui est là.
C'est bon.
Alors, Jamila, Najia, Souad, il y a Jamila qui est encore là, mais c'est pas grave.
Jamila, on l'entend pas.
Bah écoute, bravo les filles, c'était vraiment super.
On est à 3, c'est bon.
Ça y est, superbe. C'était vraiment superbe.
C'est chez toi qu'on entend parler, Nadia?
Comment, chérie?
Chez
non,
toi?
Attends. Tu m'entends là? Attends 2 secondes.
Non, on est à 3.
Oui, là, je t'entends très bien.
Bah, très bien.
Ah,
alors, je vais te mettre un peu sur... je sais pas comment on peut faire. En tous les cas...
Il y a ma cache enregistrement.
Ah ouais. Sinon, pas sur le WhatsApp, s'il te plaît. Nabila.
WhatsApp, là, le WhatsApp.